We will go ahead and get started. Thank you, everyone, for taking your lunch hour to join us. This afternoon at Gina, we're committed to pharmacogenetic testing and precision medicine, so we're very excited for this workshop with the title From Data to Decisions, Advocating for DPYD Testing to Advance Patient Safety Based on Insights from Clinical Evidence. And it's my distinct honor. My name is Glenn Sawyer. I'm the Associate Director of Clinical Genetics at Agena Bioscience, and it's my distinct honor to introduce our two key speakers who really need no introduction in the field of pharmacogenomics. But joining us today, we're honored to have Professor Ron van Schaik. He joins us from Erasmus Medical Center in the Netherlands, where he's the head of the Department of Clinical Chemistry and director of the International Expert Center for Pharmacogenetics. His list of accomplishments and credentials are extensive. A few that I would like to point out is that he's been published in over 350 peer-reviewed articles in this space. And his specific research topics include pharmacogenetic applications in oncology, cardiology, psychiatry, and pain medication, as well as ctDNA and liquid biopsy for lung cancer, all as part of the COIN consortium. He participates in several of the key national and international groups on pharmacogenetics, including ESPT, PGRN, CPIC, the Dutch Pharmacogenomics Working Group, IUPHAR, PharmVar, AMP, EMEA, the list goes on. He is the chair of the Dutch Network for Clinical Pharmacogenetics, and he is the recipient of the Ortho Clinical Diagnostics Award for Outstanding Research, as well as the AACC Outstanding Speaker Award, and the AACC Molecular Pathology Award for Outstanding Scientific Research. Thank you for joining us. It's an honor, Dr. van Schaik. And then, of course, Dr. Vicky Pratt. She is currently the Director of Scientific Affairs for Pharmacogenetics at Agena Bioscience. And she is the former past president of AMP, the Association for Molecular Pathology. And she continues to serve on the CDC's Control and Prevention, the GET-RM program for reference materials for molecular genetics, and the National Academy of Medicine's Roundtable on Genomics and Precision Health, and the American Medical Association's Molecular Pathology CPT Advisory Committee. So thank you again for joining us. The agenda for today's workshop, first we'll hear from Dr. Vicky Pratt, who will give us an overview of the clinical relevance and implications of DPYD, as well as the relevant targets and supporting evidence. And she'll provide her insights and expertise from a North American perspective. And then we'll, of course, hear from Professor van Schaik, who will show us some recommendations and resources regarding DPYD, some of the current considerations and guidelines, as well as insights from an international perspective. And if there's time at the end, we'll hear a little bit about Agena's portfolio and give you some information about visiting us in the booth. So without further ado, I welcome Dr. Vicky Pratt to the stage.
All right, so let's see if you guys can all hear me and I can not knock everything down here. So let's see. So today I'm going to talk about DPYD and 5-FU toxicity. So in the world of pharmacogenetics, this has been in the news a lot lately. There was Oregon Health Science University settled for a chemotherapy death lawsuit. A 78-year-old David McIntyre was diagnosed in September 2018 with bile duct cancer. A wrongful death lawsuit was filed by his widow in 2019, alleging that OHSU failed to advise her husband about his genetic variant and failed to timely administer an antidote, uridine triacetate, and her husband died in mid-December. So what we're talking about is pharmacogenetics, and really it's the we're not talking about the tumor per se, but we're going to talk about the inherited version of DNA testing. So pharmacogenomics encompasses both inherited and acquired genetic variations, but what I focus most of my efforts on are the inherited versions. Most of these changes variants are in drug metabolizing enzymes like the CYPs that affect efficacy and toxicity of drugs. The whole goal of pharmacogenomics is really to optimize therapy and reduce likelihood of adverse drug reactions. So today we're going to focus on our more chemotherapy drugs. The one we're really focusing on today is DPYD and fluoropyrimidines, but there's also TPMT and NUD-T15 that are involved in the thiopurines. There's also pharmacogenetics affects many other medications used in medicine, such as in the cardiovascular space, antidepressants, and pain medications. So most drugs are actually, and I'll get my animation to see if it can work, is really a one-size-fits-all model. But many people, when they take drugs, they actually can have, some people don't respond at all, some people may have a toxic response, and some may have very minimal toxicity. In a pharmacogenetic model, that it's really to do the DNA genotyping and to be able to see which people respond to the medications or to avoid getting a toxic reaction to the medications. So what are fluoropyrimidines? Fluoropyrimidines are 5-FU or capecitabine, and I will massacre every drug name that is out there, so if I stumble over it, don't be surprised. They are pyrimidine analogs used to treat solid cancers, such as colorectal and breast cancer. About 10 to 40% of patients will develop severe and sometimes life-threatening toxicity when they take 5-FU. Most of this is neutropenia, nausea, vomiting, severe diarrhea, stomatitis, mucositis, and hand-foot syndrome. About 10 to 20% of these patients are actually hospitalized for this toxicity during the treatment with this medication, and about 0.5 to 1% will suffer of fatal toxicity, such as the gentleman I mentioned when I started this presentation. Most of the toxicities in 5-FU are really related to genetic variants in the DPYD gene, or dihydropyrimidine dehydrogenase. So if we look at the metabolism of 5-FU, and I'm a geneticist, so, and I play like I know what's going on with drug metabolism on the side. So if we look at 5-FU, a patient takes 5-FU, and some of it goes through DPYD and gets excreted. But if this gets blocked, and then when 5-FU goes through it, starts RNA damage, DNA damage, and allows the tumor, sort of attacks the tumor, growing tumor cells, and helps kill off the tumor. But if some of this pathway is blocked, such as they have 5-FU can build up, causing toxicity in the cells. Again, the DPYD gene encodes for the DPD protein, dihydropyrimidine dehydrogenase, and this is the initial rate-limiting enzyme in the 5-FU metabolism. So if we block or partially block this, we build this up, and it causes the toxicities and the side effects. So DPYD and DPD deficiency encodes the initial rate-limiting enzyme important in the breakdown of pyrimidine bases, mostly thiamine and uracil, and then pathogenic variants or deleterious variants in DPYD are also associated with an autosomal recessive disorder known as DPD deficiency. And this is totally, while they are related to each other in the fact that there's variants in both that cause issues, but DPD deficiency is an inborn error of metabolism, and that's not really what we're talking about today, but just mentioning it. And it can cause a wide range of symptoms from asymptomatic severe neurological symptoms that can appear in infancy to much milder symptoms. Partial DPYD deficiency or carriers or heterozygotes in a true autosomal recessive manner are asymptomatic, and when you have complete DPD deficiency, these children usually have delayed cognitive and motor development, intellectual disability, recurrent seizures, microcephaly, autism, or growth retardation. Partial or complete deficient patients are susceptible to severe 5-FU toxicity. So CPIC in 2017 published their guideline for DPYD and 5-FU dosing, or the update to that. And in their dosing guidelines, if you're a normal DPYD metabolizer or have no pathogenic variants or only have functional variants, you get essentially the norm. You're not expected to be at risk for toxicity. If you're an immediate metabolizer and have decreased activity, which can be reduced from 30 to approximately 70%, you need to significantly reduce the starting dose based on the activity score and then follow titration. So these individuals are at risk for side effects. And if you're a poor metabolizer and completely DPD deficient, you should avoid 5-FU at all cost to avoid severe and sometimes deadly reactions. So going back to some of the cases in the news recently, the cancer centers have been starting to push oncologists to do DPYD testing. So advocates for universal DPD or DPYD testing have formed to increase public awareness about the risk of treatment in the face of DPYD deficiency. It really, when you're talking with the patient advocates, they're very passionate about it when they've had loved ones pass away with their first dose of 5-FU and they're not given the expensive antidote to prevent them passing away. These patient advocates have petitioned both the FDA and the National Cancer Comprehensive Network, or NCCN, to recommend testing prior to giving 5-FU therapies. There was a citizen petition submitted to the FDA, and in their request, they recommended that DPYD testing be done prior to administering 5-FU chemotherapy. The FDA, in their response, said they changed the label on the drugs to consider DPYD testing. And their rationale here was there's a low prevalence of individuals actually having the DPYD variants. The other thing is that there were no FDA-cleared tests for DPYD. And then there's no testing recommendation from NCCN to recommend DPYD testing. The citizen petition also requested a boxed warning regarding DPD deficiency. FDA decided not to include a box warning, and their rationale was testing concerns as described above, and the severity of cancer and the potential risk to reduce efficacy relative to the severe toxicity. So it was a risk, sort of a risk balance. And then the citizen petition also wanted to recommend dose adjustment to DPYD and intermediate and poor metabolizers. And currently there is no update on this and has retained the existing language that there is no safe doses for poor metabolizer patients and no dose adjustments for recommended and intermediate metabolizers. And the FDA's rationale was there was a lack of rigorous data that is necessary for the FDA to recommend dose adjustments, and lack of randomized controlled trials demonstrating that dose reduction does not reduce efficacy. So if we look at the labeling on, and this is from PharmGKB. So if we look at the labeling for the fluorouracils, we can see that, and Ron's going to go over this much more in detail on the European perspective. So I'm going to only really focus on the FDA. Is that they did change the label and said testing is recommended for capecitabine, but if we look at 5FU down here, that they just the label just says that it's an actionable PGX information for DPYD. So in the label, the updated label for capecitabine, it just said patient, so the updated label said it is patient homozygous or compound heterozygous for variants in DPYD are known to result in complete or near complete absence of activity and are at increased risk for acute onset of toxicity and serious, including fatal adverse reactions. I'm not going to read the whole thing, but it says essentially the recommendation is consider testing for DPYD. So they did put some information in the label for capecitabine. So because I'm a geneticist, I just want to give you sort of I got to tell you about DPYD gene. So it's on chromosome 1. It's a fairly large gene and spans about 840 kilobases. It contains 23 exons, and to date, there's been close to 2,000 variants that have been identified. Most of these variants are of unknown or uncertain function. Compared to other pharmacogenes, DPYD does not use the star allele nomenclature. There are some legacy nomenclature star alleles that are still used somewhat routinely in the literature, star 2 through star 13. There is one haplotype, and and a haplotype is where multiple variants exist on one allele. There is at least one haplotype known to occur in DPYD, but there are others that occur because from doing testing, I know that there's many others that occur, but they haven't been categorized except for the HapB3, which is its legacy name. The protein again is called DPD. So if we look at, and this is, and I've curated this at the DPYD variants, and I've only included some of the known variants and their multi-ethnic frequency. Most of these are extremely rare in the population. CPIC actually does curate this and gives them an activity score. So an activity of 0 is a non-functional variant, where an activity score of 0.5 is a reduced function variant. So, but if you look, many of these variants are extremely rare, 0% in a multi-ethnic allele frequency. We do see some more common ones, such as the 1905, the formerly known as star 2 variant, occurs at a 0.5% frequency. The HapB3, I will just tell you there is some soon-to-be published data that there are 2 variants in the HapB3. One is in the 5' untranslated region of the gene, which is known to be the pathogenic variant, as well as a variant that is in the coding region of the gene that is not pathogenic. While they are very tight linkage disequilibrium. They are not in complete linkage disequilibrium, and there will be a publication that'll be available soon on that. And I know PharmVar will be updating their website once that publication is available. So if we look at the genotype-phenotype correlation, if you have two normal alleles, you get an activity score of 2. There are some examples here of the 85 T to C and other ones, and this is called a normal metabolizer. An intermediate metabolizer will have an activity score of 1 or 1.5, so if it's a normal allele on one chromosome and a non-functional allele on the other chromosome, that'll give you an activity of 1. Or if you have a normal on one allele and a reduced function on your other allele, that will give you a 1.5 activity score. There are some examples from the CPIC guidelines here to give you some sort of examples of that. And then the poor metabolizers have either 2 non-functional alleles or a non-functional and a reduced functional allele, and those are poor metabolizers, and some examples in the CPIC guidelines. So just to give you an idea, this is from, was published online, but the data comes from the National Institutes of Health Genetic Testing Registry. But it gives you an idea of some, and this is alphabetized, that some of the common variants that labs actually test. STAR2 is very common, at least here in the largely, most of these are US laboratories. So STAR2, STAR13, D949V, the Hep B3, this PY186C, this is a variant that's more common in people of African genetic ancestry, and you can see a fair amount of labs actually do that, and as well as other variants in DPYD. So there actually have been clinical validity studies that have been done around DPYD testing, and that's to see what the positive predictive value and the negative predictive value is around DPYD. So if you look at just this formerly known as STAR2, if you look at the positive predictive value, and most of this is related to this as a targeted test that only tests for 3 variants. But the positive predictive value for a greater than 3 grade toxicity is probably in the 60s to 50% positive predictive value. But really, if you're negative for these, the important thing is that if you're negative for these variants, you don't get that grade 3 toxicity. Again, this is sort of a limited study here, just done for a targeted panel of 3 variants. So in conclusion, individuals with decreased or no function variants are at risk for severe toxicity and even death when prescribed 5-FU, and targeted testing for DPYD variants prior to prescribing fluoropyrimidines will help identify individuals at risk for this toxicity. Thank you. We have Ron, I guess we'll have Ron come up. We're making decisions here. Ron, you'll come up and then we'll just take questions. How's that sound?
Okay, thank you very much for the kind invitation and the great introduction. I was a little bit afraid now to come on stage because you set the bar very high now. I'm going to talk a little bit about pharmacogenetics in oncology, DPYD testing in Europe, and of course, because I'm from the Netherlands, starting from the Netherlands there. You can see here Erasmus University Medical Center. It's where I work. It's the largest academic center in the Netherlands, something like 1,200 beds. and 19,000 employees. And just to point out a little bit, we have a specific children's hospital there. The university building is integrated into the hospital complex. We do in pharmacogenetics a lot with the psychiatry, so that's why I indicated them here. And we have the Daniel Den Hood Cancer Center, a well-known center looking into oncology. And my lab is exactly there in the middle, so very nicely located, so I can access all the clinical disciplines easily. If we talk about capecitabine and the DPYD, I think this is the clear example that was already given by Vicky. 10 to 30% of the patients develop severe grade, more than grade 3 toxicity, and 1% of the patients actually die because of the therapy. DPD deficiency occurs in 3 to 5% of the population, and the most known allele there is the STAR2 allele. You can see here, if you don't have the DPD enzymatic activity, you get more of the active metabolites, and because of that, this high toxicity. I would like to point out 5 important papers that drove the implementation of pharmacogenetics in the Netherlands, and also I think in Europe. And this is the first one. This is a prospective study on DPYD by Dana et al. Patients that were upfront genotyped for the STAR2A allele, and based on that got a dose reduction of 50%, and compare that with patients that were also genotyped but were found to have not having this variant allele, and they got the normal dose. Of course, you would like to compare that, but since it's not ethical to have the full dose of patients that have the STAR2A, we went back to the literature and compared it there. We found 48 patients which were treated with the full dose. And based on this, you could see that if you are a STAR2A carrier, so this is in fact an intermediate metabolizer, there was 73% of the patients had this severe toxicity. However, if you would genotype up front and lower the dose by 50%, you could see that there's a significant reduction in the toxicity and goes to 28%. Well, some of you may say, that's still 28%, it's still a lot, but if you compare that to the patient that were not carrying this STAR2A variant allele, also there's 23% toxicity still remaining. So what this study shows, that you can significantly reduce the toxicity from 73% to 28%, which is comparable to patients that are not having this STAR2A carrier. The second paper, which I think was very important, is to look for additional SNPs besides the STAR2A allele. And this is a paper we published in Lancet Oncology, and what you can see here is an overview of the 4 SNPs that we investigated. You can recognize the STAR2A, and let's see if the pointer works here. You can see there's several studies, but this is the most important one. It's significantly increased risk on toxicity if you're a carrier of the STAR2A. Then we have the 2846 here, the SNP here. There's the STAR13, and this is the 1236 or the Hep B3. And you can see all have an increased toxicity, and this was a study showing, looking at all the literature available, that these SNPs make that you have an increased risk of toxicity. So that led to the third paper, which is an important one. This was the randomized controlled trial, which we did in the Netherlands, published in Lancet Oncology in 2018. And again, you can see the toxicity in red of the 4 SNPs there. So if you're carrier of the STAR2A, then you have approximately 2 to 3-fold higher risk of toxicity. This is the STAR13, and these are the 2 other SNPs. And what we did is genotype them up front, and based on that, reduce the dose in 50% for the STAR2A and the STAR13, or 25% here for the other SNPs. And by doing that, we could show, again, that the STAR2A carriers, they reached a toxicity which is comparable to the rest of the population not carrying mutation, and the same for the 2846 there. So with this study, we showed that genotyping up front and adjusting the dose will indeed reduce toxicity. And again, I was a little bit surprised to see that the FDA claims that there's no data on intermediate metabolizers. This is data on intermediate metabolizers. Of course, the question is then, are we not undertreating the patients? And that has been an argument which have been asked also a lot in the EMA and advisor there as well. Well, we looked in this particular study also on the 5-FU levels. We looked at the several ones, also capecitabine, and on the different metabolites, but this is the most important one. Of course, 5-FU is like the most important component here. And you can see that there is no difference between the ones that are DPYD variant carriers here in blue that got a reduced dosing with the wild types that got the normal dosing. So you can see the exposure in 5FU is identical, so you do not expect any decrease in activity. The fourth paper, which is then important, adjusted dosage and the outcome, because you could still argue the 5FU levels are the same, but does that also result in the same outcome? And this was a study just published in 2023 from Knickman et al., looking at the same patients, and now we followed them up for longer. And you can see if you look at the overall survival between wild type and DPYD variant carriers that got a reduced dose, you can see that there's no significance in overall survival. So I think that the fear of that we would be under-treating these patients, we do not find any evidence that that would be the case. And even you can see that if you specify for the STAR2A, you can see that we even have a little bit increased overall survival, because apparently, although we reduce the dose with 50%, because they cannot metabolize that easily, I think they're still exposed to a little bit higher than the average exposure to 5FU. Okay, so we just talked about this one. So this is the fifth one, because now that we have shown that you can reduce toxicity, that the outcome is the same, then people say, well, what about the costs? Well, this is the next paper that we published on this study. We found that in the Netherlands, if you do not do DPYD genotyping, the average cost per patient is 2,650 euros. If you do preemptive DPYD genotyping, you can see that the costs are even lower, 2,599 per patient. And just to be clear, because that may be different between the countries, the DPYD genotyping in the Netherlands is about 80 to 100 euros per patient. So the conclusion of this particular paper is that upfront DPYD guided dose individualization improves patient safety, but is also even cost saving, or perhaps even cost neutral, but there are no additional costs. So you get a safer treatment for your patients at no additional cost. And I think that's a very important argument. So then what about the guidelines? As pointed out, the European Medicines Agency got a guideline out on Xeloda, and here it indeed states that EMA has recommended that patients should be tested for the lack of the enzyme DPD before starting cancer treatment for fluorouracil given by injection or infusion, or with related medicines. I think I just noticed that this is an important difference a little bit between the FDA label and the EMA label, because the EMA label talks about DPD deficiency, whereas I saw that the FDA label talked about the specific SNPs. And also here in the EMA, the SNPs are mentioned, but it just indicates the 4 DPYD variants, which were also in our study, give rise to complete or a reduction of DPD enzymatic activity. Other rare variants may also be associated with an increased risk of severe or life-threatening toxicity. So important here is to notice that the 4 variants that we tested in our study are in fact taken up here in the EMA drug label. Also, the European Society of Medical Oncologists came with a guideline, and this is from 2022, looking, for instance, at metastatic colorectal cancer. And also here it stated that patients or testing for DPD deficiency should be conducted before initiating these drugs. So I think this is also very important that not only the regulatory agency, but also the medical oncology group, at least in Europe, is advocating for upfront genotyping. But then, and I already addressed the question a little bit, are we going to do genotyping or phenotyping? Of course, the drug label states that we have to be aware of decreased DPD activity. Well, in the Netherlands, we do the genotyping. 4 SNPs before start of the therapy. I first thought that was mandatory, but I don't think that it's that strong. But I know from the practice that every patient in the Netherlands gets tested for these 4 SNPs before they start the therapy. We are doing something like 1,500 DPYD genotypings at Erasmus. We are one of 16 centers in the Netherlands, but I know that if the genotype results are not available, the patient will not start on the therapy. And that's even quite new. I haven't seen that before. So that means that the oncologists are very much aware that they want to have this available. In other European countries, and I listed some of them, Denmark, Italy, Spain, Germany, etc., I also know that they do genotyping before starting of the therapy. I'm just not sure if every oncologist does that, so I don't know how widespread it is. And you may notice that France is not here, because France is a little bit exceptional. In France, they say we believe more in the phenotyping. So they want to look at the uracil levels before start of the therapy, and in that way, they are the exception in Europe. There's a lot of debate there on whether this phenotyping is accurate or not. We did some studies on that ourselves, and we published this. We had a poster on ESMO in Paris last year, and we're working on the article here. But we can see here, this is the DPD enzymatic activity, so the classical enzymatic activity measured against uracil concentration here. And you will agree with me that there is hardly any correlation there. And we had a study ongoing in which we were in fact dosing based on the uracil levels, and we had to stop that because, of course, we could see that the patients were underdosed, the 5-FU levels were too low. So based on this, I would not be a strong advisor of using the uracil test to guide the therapy there. We also set out a survey in Europe to see what is the uptake of the DPD deficiency testing or the DPYD genotyping. So we approached some colleagues that we knew, 12 labs in France, the Netherlands, Germany. You can see in total 74 labs from 17 countries, asking them about the DPYD testing. And one of the questions that we had is the uptake of the recommendation in the EMA guideline, if that would have changed the number of genotypings there. So you can see here 2019 and 2021 are being compared. So in 2020 there was the EMA guideline. You can see that the numbers did not increase in France if it's about the genotyping, because they hardly do the genotyping. Austria also not. Then we have like some 1 to 5 times increase in Iceland, Spain, Italy, Poland, Croatia, Greece, Estonia, and Bulgaria. In Germany, we had a bigger increase, 5 to 10-fold, and the largest increase we could see in Norway, Sweden, Finland, Denmark, Portugal, and Switzerland. So apparently having it in a drug label triggered to have like more genotyping done. If you look at the guidelines which are being used in Europe, so that's also what we had in the survey, you can see that CPIC has a major part of that. So that's here in red, but also in this one in green and in purple here. So like the majority of the labs use indeed the CPIC guidelines. And secondly, 34% of the countries that use the national guidelines, which may also very much be based on the CPIC guidelines there. Reimbursement is also an issue, so we asked that as well. You can see here where there will be reimbursement. And the countries where there's no reimbursement are here in the pink. So that's only a minority of the countries. In most of the countries, there is reimbursement, either unconditionally or based on certain conditions, like an oncology must have requested the test. If I look at my own country and reimbursement in the Netherlands, I always think it's a little bit difficult to talk about that. And the reason is the following. The hospital gets a fixed amount of money for every colon cancer patient. It's up to the oncologist how they want to use this money. So if you compare that, at a certain moment, the oncologist just decided that they thought it was worthwhile to do the DPYD genotyping for these 70 euros, just to make sure that the patients are safe. And if you compare that with just the surgery on colorectal cancer, it's something like 13,000 euro. And I'm not even talking about the genotype or the chemotherapy. So the 70 euros is just negligible compared to the total cost there. So it's really the decision of the oncologist as a group and as the hospital to decide that they would use their budget to do the DPYD genotyping. So again, within the hospital setting, it's the choice of the Department of Oncology to perform the genotyping. And there's no talking about reimbursement or whatsoever. It's just integrated in the total costs. DPYD genotyping got in like 2-3 years completely adopted in the Netherlands. So because of this meeting, I thought, what was now the reason why we had such a great uptake? Well, we had this randomized controlled trial, which I showed you, which was published in Lancet Oncology in 2018. And we started with 12 centers, but more and more centers wanted to participate. So in the end, we had 17 centers that participated in this particular study. And as a result, we could see that the clinicians got used to having the DPYD genotyping result. The infrastructure was there. They knew how to deal with the result. So in fact, the clinicians started to do the DPYD genotyping also outside the study as a general care, because they were at that moment convinced that they could use it, that was safe for the patients, and they knew what the infrastructure was like. So actually, even before we had the results of the study, everybody in the Netherlands was already doing DPYD genotyping. I would like to address then the fact that we only look at 4 SNPs, because the 4 SNPs are now in the EMA drug label. But we can have local diversity, we could have local changes. And we found even one in the Netherlands, because the testing panel which we had included the star7 allele. So that's indeed a 4-base deletion causing a frameshift mutation that leads to a premature stop codon. So you would not expect any activity. And we were triggered by one patient that was sent in that actually died without having one of the 4 known mutations. And then we looked at the genotyping results that we had, and we noticed that he was carrier of this star7 allele. So then we went back into all our results to see if we could find more patients and see what happened there. And one of the surprising findings here is that the frequency of the star7 allele in the general population, the minor allele frequency is 0.0007, very, very low, and that's why it never showed up in any panel. But in the Dutch population, in our database that we had, we found that the allele frequency was between 0.2 and 0.4%. So that's 40 times higher than in the general population. And because it is a truncated protein, I think it's very important that we also analyze this. So from the Dutch perspective, we now have this 5th one that we added. And of course, that's also more important than for the rest. Because if we look at the toxicity, we found that 46% of patients developed severe adverse events, even if some of them already had a dose reduction up to 60%. So showing that this particular variant is also of importance to include, at least in the Netherlands. And with that, we come to the global perspective. Of course, there are other populations that also have variants that are less frequent in their population. So currently, the 4 SNPs may need to be extended, and we would also include SNPs that are of clinical importance in other populations. And for clinical importance, I think that's very important. So there should be a certain frequency, the clinical consequences should be known, and preferably you should also know what is the effect if you adjust the dose. As you may have heard already from Vicky, like DPD deficiency, to test or not to test is still the question. And there is a very nice editorial from Ingolf Kaskorbi in CPT in the October looking into this. And also showing like the different agencies that recommend testing. So the first one, the European Medicines Agency, the testing is recommended. The FDA, actionable gene. The Swiss agency, testing is recommended. The Japanese group, also actionable gene. And also the Santé in Canada, testing is recommended. So it all says testing is recommended. And I think that's a very strong advice that we should use. And with that, you come to the point that if you have your patient, why do we just prescribe the normal dose, and if things go wrong, we then think if we should have another dosing. So it's a little bit a variant on this one, like why try first, just do the genotyping first and have the appropriate dose right away. So with that, I come to my summary. I hope to have showed you that DPYD genotyping for adjusted capecitabine dosing, it significantly reduces risk of toxicity. It gives an equal effectivity in the dose reduction groups. It's cost neutral or even cost saving, and you protect patients at no extra costs. It's technically and logistically absolutely possible today. That's not a problem. And it should preferably include more than the 4 SNPs that we now have in the EMA guideline. And with that, I would like to acknowledge my co-workers that were part of the different papers I showed you from Erasmus MC. Especially want to acknowledge Ron Matthijssen, so the oncologist I work very much together, and Mirjam de Wit, who did a lot of the papers that I was showing you. And of course, the group that did the randomized controlled trial. And then we have from the Leiden University and an Amsterdam Cancer Center and some international collaborations. Thank you very much for your attention.
So again, thank you to both Dr. Van Schaik and Dr. Pratt, and just very insightful for DPYD testing. And they showed the importance and the relevance of DPYD testing and how it can help patients and improve safety. And Agena, being committed to pharmacogenomics testing, we do have a DPYD panel available. Now, as Vicky mentioned, there are no current IVD approved panels, but so we have an RUO panel that is available. It does include 9 SNPs for genotypes. You can see all including the high toxicity risk variants as well. And this allows for highly accurate genotyping for DPYD and DPD activity prior to treatment with the 5-fluoropyrimidines, and we just saw the importance of that. And it can also be used, this panel can be used in conjunction with our existing panels to get a more comprehensive look at pharmacogenomics testing. So we do have an off-the-shelf panel that is robust for 73 targets for 20 primary genes, and we'd be happy to discuss PGX further with you if you come visit us at the booth. And again, these can all be run in conjunction together on this single run, all at the same time on the platform. And we also have a CYP2D6 copy number variant panel, which is comprehensive, which allows us to get a true picture of the hybrid alleles, which is very important in CYP2D6 testing. So again, we'd love to talk to you more about this if you come visit us at the booth. And what makes this all possible for us is our platform. So it is the mass array system, which is a benchtop genetic analyzer that you can see on the left. You have the tower, that's the mass spec, and then the liquid handling, which is on the right, which does all of the preparation for you, so fully automated. So again, a plug for an upcoming webinar, because we are committed and passionate about PGX. So on December 4th, we are having a webinar to discuss further PGX testing developments and future directions with both Dr. Bronwyn Ramey as well as Dr. Vicky Pratt. So we'd love for you to join us with that if you're available. And with that, I thank you for your kind attention, and I open it up for questions. And we are located at booth 1011 and hope to see you there. Thank you.
You indicated about 23% or so of people who don't take positive for these SNPs also show toxicity. Do you think those are variants in areas that haven't been tested for, or potentially somewhere else on the metabolic pathway?
I think there are a number of possibilities why there's still remaining toxicity. Being into genetics, you always think that there might be like some SNPs that we did not identify, but it could also be some drug-drug interaction or just some variability, other genes, other factors there. So I'm not sure if we would be able to reduce that toxicity even more if you look at more SNPs.
And in the prior institution that I had, some of those toxicities were actually rare variants in the DPYD that were not tested for.
Okay.
Back first.
Dr. Pratt, starting with an arresting example. If I recall correctly, you said that they brought the lawsuit. Did they win the lawsuit, or it's only been 6 years, so maybe it's still going on? And what would be the ramifications if, in fact, they had a rare variant, possibly going to be significant? Should we not be sequencing everything and putting disclaimers on all the patient notes?
So the lawsuit was settled. The amount is undisclosed. So I have no more information than that. So that's your first question. Your second question was, should DPYD testing or sequencing be done for the entire gene? That was your second question?
Well, basically, did he have a rare, I mean, if they say...
Unfortunately, I don't know what rare or what variant he had or did not have. I do know of other cases, or many other cases, because some of the advocates for DPYD testing, Karen Merritt, who has spoken in many places publicly, her mother had a star 13 variant and passed away from a fatal toxicity. Unfortunately, the Oregon State, I do not know what their pathogenic variant was.
Karen Wood, I have a question for Ron. So thank you for all your work on this. I think you're really helping to improve the safety of patients with DPYD deficiency. I guess my question is, with over 1,500 variants that have been observed, I mean, unless you're sequencing, which is difficult to do, we're not testing for all of them. So it seems that a phenotypic test would be more efficient, but it hasn't worked out. And do you have any insight as to whether there isn't a good correlation between the urinary phenotypic tests and the metabolites, and why that hasn't borne more fruit?
So I think that the uracil as an endogenous marker, there's several aspects that play a role there. So one of the important ones is that there is a large variety between the different labs. So it's very difficult to standardize. So that means that you can have in one lab a value of 30 and the other one will have like 10. So if you have that much variability, it's very difficult to compare. So that's one. Also, I think the pre-analytical conditions make a very big difference. So if the sample is too long out there, it will also change. So this is already the technical part, so let alone that if you could actually establish the right level, then you still have to show that it correlates with DPD and enzymatic activity, and then also with toxicity. So I think that you would expect the phenotyping test to be better, but then perhaps you should just measure DPD enzymatic activity. But that's quite a cumbersome test. Yep.
Yeah, since the prevalence is so low, what's your strategy for the clinical validation? Because the analytical validation is very easy.
Yeah.
Right? The clinical validation, or even one step further, how you establish a clinical utility so your assay actually will get results with the maps.
Well, I'm going to sort of jump in for that. Ron has presented fabulous evidence on the clinical validity.
Well, yeah, no, clinical utility now.
So, but he's also, so clinical validity, he's printed, but even the utility of that, usually utility can be in the eyes of the patient as well as the payer, of the usefulness of testing. And so there was a study done that I presented in my talk that looked at the positive predictive value, negative predictive value. Well, that's largely clinical validity, but it does point to sort of the utility of the test too.
But there is like one aspect that is a little bit behind your question, which I think is very interesting. Why do we think that doing a genetic test will be 100% effective in reducing all the toxicity? It just decreases the risk. Like the same like with like a high cholesterol, you try to lower it to lower the risk. So sometimes I think we are expecting too much from a genetic test.
No, I'm not talking about the test have to be accurate. It's really the payers asking you for clinical validity. Now they set the bar so high, is they look for guidelines.
There are guidelines.
Yeah.
Yeah,
CPIC.
there are no guidelines, right?
There's CPIC.
Yeah. See,
EMA, FDA recommended testing.
I understand, hospital-based labs and academic institutions, we pretty much just absorb the cost because it's so cheap. But still, how you prove clinically they are very effective because the prevalence are so low.
So that's with any rare genetic disorder that if you're looking at, from a point of view, the rarer the disorder, the harder it is to prove. Niemann-Pick disorder or something like that, the rarer the disorder. And DPD deficiency is actually a rare disease overall.
With that, I thank you for your time. We can take questions out in the lobby after. We have to be respectful of the next session coming in, but we look forward to speaking with you and seeing you at the booth. Thank you.